Good morning and welcome everyone to this week's Insight APSAD webinar. My name is James. I'm one of the clinical educators here at Insight, and it's my pleasure to welcome you along this morning. I'd like to begin by acknowledging and paying my respects to the traditional owners of the land here in Brisbane where we meet, and those lands of where you're meeting today, and also pay that respect to elders past, present and emerging, and extend that respect to any Aboriginal or Torres Strait Islander people who might be joining us here in the room today at Biala or out there in webinar land. So for today, we have two of our wonderful colleagues from the ADIS 24/7 Alcohol and Drugs Service, Heidi and Michaela. I'll let them introduce themselves a little bit further in a few moments' time. And they're speaking, I guess, working in the alcohol and drug field, we always know that there's new and better ways to do things, and it's always a search for that. And some of the innovations that are happening in this space with the program that they're going to speak to today, I think are very exciting and very timely to be able to bring health responses to a potentially vulnerable group in a timely way is so incredibly important. So with that today, both Heidi and Michaela will talk to you about their program. Feel free to pop any questions that you have for Heidi and Michaela in the chat today. We'll look at those. We'll try and get through as many of those as possible at the end of the session. So apologies in advance if we don't get to all of them. So without any further ado, I'd like us to please welcome our wonderful ADIS colleagues. Thank you.
So as James said, we'd like to acknowledge the traditional owners of the land in which this event takes place and pay respect to elders past, present and emerging. So I'll just introduce myself. My name's Heidi Deifel-Carlino. I'm the project lead for RHODES and the senior counsellor and trainer with ADIS Alcohol and Drug Support. I've been with ADIS for the last 11 years. And presenting with me today is Michaela Boyce, who's the project officer for RHODES, and she also holds a substantive position with ADIS as a counsellor, and she's been with the ADIS service for the last 2 years. Before we begin, we just wanted to take the opportunity at the beginning of the presentation to acknowledge clients that have passed away from substance use and suicide after release from prison. We also wanted to acknowledge clients that took part in the program, especially for their openness and their strength in sharing their journey and wisdom at an exceptionally difficult time for them. And we appreciate the trust that they afforded us. Just to start with, I'll give a little bit of information on the service that we're from in case you're not familiar with the ADIS service. So ADIS is a Queensland health service, part of the mental health, alcohol and drug services. We're a confidential support service for people in Queensland with alcohol and drug concerns, their loved ones and other health professionals as well. A bit more about ADIS. ADIS has been around for over 30 years and was first developed in the 80s with the commencement of the National Drug Strategy in Australia. So each state has an ADIS service as a similar point of contact for individuals seeking support. We're a statewide telephone-based service located in Brisbane here at the Biala Community Health Centre, and currently we receive over 3,000 inbound calls per month and around about 1,900 outbound calls per month. Our team of experienced counsellors provide information, brief intervention, counselling and referral to reduce harms associated with substance use. Our clients can be from anywhere in Queensland with substance use concerns. We talk to a lot of family members or significant others who are concerned about somebody else's substance use. And often people contact us when they're seeking treatment such as rehab, detox or opiate treatment therapy. Staff provide brief interventions related to reducing harms associated with substance use, such as the development of relapse prevention plans, assisting with managing cravings, goal setting, motivational interviewing. And ADIS has a model of care that has 3 overarching frameworks of person-centred care, harm reduction and risk assessment and management, which would be implemented into every client contact. ADIS provides an opportunity for early intervention and it aims to improve accessibility to treatment for people, creating an environment for individuals where they can access treatment at a time and place suitable to them. So obviously we know it can be quite overwhelming to reach out for support for the first time, and there can be significant stigma around substance use, preventing individuals seeking treatment from their primary care providers. We know that only 1 in 5 people with substance use disorder ever seek treatment, and it can take on average around about 18 years for a person with problematic alcohol use to reach out for treatment once they realise there's a problem, and around about 7 years for people using illicit substances. So during this time, there's huge costs to the government with societal costs in relation to alcohol misuse, with most of that burden being seen in ambulance and hospital emergency departments, but also through the criminal justice system, lost productivity and traffic accidents. And out of people who are motivated to make changes to their substance use and meet criteria for treatment and are able to access an appointment, we know that only 50% of those people end up attending appointments. Doesn't sound very positive, does it? Just another part of the ADIS service I think that is important to touch on is ADIS Link. A common theme that we see among people seeking treatment is that the alcohol and drug space is difficult to navigate with specific criteria for different treatment services. ADIS aims to streamline treatment for individuals seeking ongoing support, reducing the need for clients to have to repeat their story and taking advantage of the client's current motivation. So ADIS has developed direct referral pathways into treatment with Queensland Health, alcohol and drug services, and also NGOs for counselling, withdrawal management, opiate treatment therapy, residential rehab and day treatment programs. Counsellors would complete a biopsychosocial assessment during the brief intervention or counselling session, which is then forwarded on to treating services to reduce the need for reassessment. The list of direct referral pathways is currently continually growing, but currently we have over 60 in place. Within the ADIS team of counsellors, there is a smaller team, the Suits team, who work on the model of booked appointments. Primarily, this is telephone, police and court diversion appointments, but it also has recently included some brief multi-session interventions aimed at reducing barriers to treatment. Multi-session interventions have been trialled and were prioritised for individuals who were unable to access services for a variety of reasons, or maybe they met criteria for more mild to moderate substance use disorder. Some of the barriers to treatment may have included things like their location, employment obligations, being more moderate complexity, transportation, childcare, or financial barriers. As most clients supported by the Suits team are mandated clients being referred through by the police and courts for minor drug offences, often these individuals are pre-contemplative or contemplative about making changes to their substance use. And this has enabled the team to develop a lot of skills in supporting this population. So that brings us to the RHODES program, which we're here to talk about today. So RHODES is the Released Offender Alcohol and Drug Support Service. So just a bit of a timeline about how the RHODES program came to be. In 2017, or around about there, ADIS staff noticed there was an increase in calls from people who were engaged with community corrections. There'd been a lot of talk and changes at the time implemented around supporting people released from prison due to large amounts of research based on drug-related harms being seen in this period. In 2018, we started consulting with other people working in this space, and that included Queensland Corrective Services, re-entry teams, prison health services, other alcohol and drug treatment services and NGOs, and they were all experiencing the same issues and concerns for their clients. So if service providers at the time were finding it difficult, then how could we expect clients to be able to navigate the system? So in 2019, we started seeking funding avenues to look at working in this space to address the gap. We submitted an application for funding through Seed and Link, and luckily we were successful. So in 2020, we received that funding and we began the program trial. So we had 12 months to map this space, develop a program, trial it and evaluate it. And here we are in 2021, coming to the end of the trial at the end of June. So when we submitted our funding application, we were looking at what the client experience was currently at that time and how potentially that might change. So I thought it might be helpful to share a couple of examples that were provided by Brisbane North Community Corrections at the time for what was occurring with people they were supporting. So just be mindful these stories might be triggering for some people as they do talk about overdose. So first, I'm just going to talk about Samantha. So Samantha was a 44-year-old woman who had struggled with lifelong addiction to alcohol and heroin. She spent the majority of her adult life in and out of custody, and her children were taken into her care. During her last period of incarceration, Samantha was offered transactional support, including post-release accommodation. On the day of her release, Samantha presented an excellent physical and mental health. She agreed to go to counselling to address her substance use concerns and was booked in for the first available appointment in a week's time. The following day, a call was received by her supervising officer advising that Samantha had passed away the previous night. After the re-entry worker had dropped her off, Samantha purchased a bottle of wine, made unsuccessful attempts to contact her children, and feeling vulnerable and alone, called her dealer, where she was injected with the usual dose of heroin. However, with her tolerance being reduced after 4 months of abstinence, along with sedative effects of alcohol, she suffered from an overdose and stopped breathing. So despite best efforts of the paramedics at the time, Samantha died a short time later. Samantha's death by overdose was avoidable and is representative of women who, despite best intentions to abstain from drugs on release, find themselves returning to established coping skills shortly after. Intervention on the day of release could potentially have prevented her unnatural death. I just want to talk a little bit about Matthew as well. And Matthew was a 38-year-old man with a lengthy history of incarceration related to his heroin use after the breakdown of his marriage. Having limited accommodation options, he nominated his father's address to reside at post-release, despite having a strained relationship with his family. Matthew struggled with turbulent home life and found it difficult to reach out for support. And due to lack of available services, he was placed on a wait list to address his substance use with a counsellor. And in the meantime, did his best to abstain from drugs and comply with parole conditions. After an argument with his father, Matthew took several prescribed Valium tablets and used some heroin. So the sedative effect of Valium combined with heroin caused Matthew to stop breathing. He was found unconscious by his father, who tried to revive Matthew in a cold shower rather than calling an ambulance, not wanting to get Matthew in trouble with the police. So Matthew died a short time later. Matthew's story is typical of a number of males who die of overdose, with males finding it harder to seek support and establish close emotional connections with others. With counselling services at capacity, men like Matthew usually wait several weeks post-referral to get the help that they need. So as you can hear from those stories, people within this population are known to be at extreme levels of social disadvantage, with high levels of substance use, mental health concerns, homelessness, family dysfunction, and they often have difficulty adjusting post-release. Treatment services do their best to support these people. I actually do believe that, but waiting lists prevent immediate access to treatment. To further understand these concerns, we'll just look at some of the statistics. So treatment services generally are seeing an increase in referrals from corrective services, with the Australian Institute of Health and Welfare report from the National Minimum Data Set showing over a double of referrals over the last 4 years. And even within ADIS, we're seeing an increase of calls from this client group tripling between 2013 and 2018. We've recently been seeing the commencement of opiate substitution therapy into Queensland correctional centres based on the parole system review changes. And additionally, I think it's pretty important to note that within Queensland, we actually have the highest level of offenders to operational staff within community corrections at around about 31:1. So people who have been incarcerated, we know that they have higher levels of mental health concerns, chronic diseases, bloodborne viruses, chronic health problems, and suicidality when compared to the general population. And almost half the mortality rate of ex-prisoners is due to drug-related causes. Most of these deaths, they're occurring within the first 2 to 4 weeks of release due to reduced tolerance, and non-fatal overdose is actually 20 to 30 times more common when compared to the general population. We're seeing a suicide risk 4 times higher in men, particularly in the first 2 weeks post-release. And for women, it's around about 30% higher than the general population, but that's within the first year. So we have this gap that's been identified. So how could the gap be solved? So as counsellors, we often ask our clients the miracle question. If you were to wake up tomorrow and everything had magically changed overnight and your problem had been solved, what would it look like? Well, I guess clients would be linked into appropriate services. There would be no wait lists, and clients would have knowledge of what services were available for support. Except as alcohol and drug staff members, we all know services are at capacity, and a lot of clients might not have the motivation or even be in the headspace to be able to process what they need to do after release. And the system is difficult for services to navigate, let alone for clients. However, with all of this in mind, the RHODES program idea was developed as a way to close some of these gaps. So to improve outcomes for this client population, ADIS and Brisbane North Community Corrections agreed to work in partnership to reduce harms for these people. So an information sharing deed was developed to be able to share information between the 2 government services, whilst also at the same time maintaining client confidentiality. So what is RHODES? So RHODES is a telehealth intervention which is offered over the phone. So it's a brief intervention with 4 sessions across the first month of release from prison. Clients are referred within a 48-hour timeframe from referring agencies, and sessions are tailored to individual client needs and treatment matched based upon those needs. RHODES counsellors would be assisting clients with step-up care where appropriate in the form of referrals. So just around the aim of the project, the RHODES project trial was intended to address 3 main aims. So first, to reduce associated harms in relation to substance use on release from prison, including the reduction of accidental overdose, suicide and criminal recidivism. Secondly, to address the disconnect between Queensland Health, Alcohol and Drug Services and Queensland Correctional Services by providing a cost-effective way to manage increasing demand. And thirdly, for the first contact with clients to be made within 48 hours of release from prison to offer immediate support and intervention. So how were clients referred into the program? The RHODES program referral begins when a client attends an intake appointment with Community Corrections. Usually upon release, there's a requirement to present quite soon to correctional services, to Community Corrections. So when the client attends an intake appointment with Community Corrections, as a result of the appointment, the client might be eligible for the RHODES program. If the client consents, the duty officer will complete a consent form and send a referral through to ADIS. As we'll speak about further, clients having access to phones at time was a barrier. So where possible, the duty officer might have provided capacity for a client to make the first call at the Community Corrections Office. The ADIS counsellors endeavoured to contact the client within 24 hours of receiving the referral, though it was usually much shorter than that. Upon completion of sessions, the ADIS counsellor would send Community Corrections client attendance. So criteria for engagement in the program. Clients had to consent to be referred into the program as it's not a mandated program. Clients were based for the trial within the Metro North Hospital and Health Service region and were attending one of the participating Community Corrections or re-entry services. Clients needed to be at least 18 years old as the program was tailored towards adult clients, and they had to have been released from custody within the last 24 to 48 hours due to the aim of connecting people at that high risk time. Clients were to be identified as having substance use concerns, And clients identified with mental health concerns should have been linked at that time with a mental health service. As ADIS in the RHODES program is a specialised alcohol and drug service, it is out of scope of the program. However, we do understand the relationship between substance use and mental health, and we would endeavour to take this into consideration when we're working with clients. So identified history of substance use is a fairly broad statement. Corrections identified suitable clients through a variety of ways, such as current substance use. Perhaps they had a history of substance use or non-fatal overdoses. If the client had experienced or was being treated for withdrawal symptoms when they were incarcerated, if there was offending behaviour related to their substance use, if they'd been found to be using substances whilst they were incarcerated, or maybe they had attended alcohol and drug education programs when they were incarcerated. Why did we include the content that we decided to include within the RHODES program? Well, as the first RHODES session would fall into that first 48 hours of release, it is imperative for counsellors to be able to quickly assess risk. Using a brief intervention was a suitable way to encourage clients that might not have engaged in treatment before, and hopefully having a positive interaction with a health service would encourage them to connect with support in the future. Best practice recommends the use of harm reduction to reduce morbidity and mortality. In addition, evidence from numerous large-scale trials supports the efficacy of cognitive behavioural therapy for alcohol and drug use disorders, showing significantly better outcomes. So CBT was employed within RHODES, particularly in identifying triggers to use and high-risk environments, and then developing a plan to recognise, avoid and cope with these issues. The ASSIST screening tool was used due to the introduction of Stigma, a mental health database. This was utilised further to understand the client's substance use history and to be able to offer feedback to the client. This population is often seen as treatment resistant, which I don't actually like that term, though when being placed in an environment where a person has no control over anything in their lives and the only control they have is to refuse treatment, we understandably expect that. Staff remained trauma-informed at all times, giving the client control over what was covered in sessions and what was disclosed, and also being flexible to emerging crisis and creating an environment of safety at all times. So due to the overrepresentation of Aboriginal and Torres Strait Islander peoples in the prison system, staff employed a culturally sensitive approach. So, here we've got a little bit of potentially what the content covered in sessions would look like. Obviously, we want to be covering harm reduction and risk assessment due to the aims of the project. So we want to be covering that in sessions, but other things that were included was psychoeducation, managing high-risk environments, creating a routine, emotional regulation, goal setting, normalising transition into the community, and self-care strategies. We know a lot of these things would be helpful in this space, but clients always have control over what happens in sessions, how many sessions that they engaged in, what content they wanted to cover. We know there's high levels of trauma in the alcohol and drug space, but particularly for clients we're supporting through RHODES. Well, I might just hand over to Michaela to go through a case study and some of the data.
Thank you. I guess this was a really important part of RHODES, was to share a client's experience of what it was like to go through the program. So I'd like to introduce you to Max. So we received a referral from Brisbane North Community Corrections. Max was released just the day before he was referred to us, so very much within our time frame. Max identified to have a long-term history of polysubstance use. He was really seeking support for assisting him not to relapse, and then how that kind of impacted whether he would return to custody as well. And Max didn't report any current concerns of mental health. So as you can see, there is a bit of a very complex kind of example of what we would cover in sessions. But more simplistically, I guess, for Max, he was a man in his 20s, really seeking support for methamphetamine post-release. So Max had been abstinent from methamphetamine and Suboxone for the final 6 months of incarceration. However, prior to that time, he was using Suboxone, which is quite common that we found through working with clients. He had reported no use since release, so over that 48 periods hadn't used anything, which is really positive. And his big goal was remaining abstinent from that. He reported previous history of IV drug use, and he spoke a little bit about his substance use beginning when he was about 17 and then increasing as he, I guess, got older. He was diagnosed with hepatitis C. He was receiving treatment whilst he was incarcerated, however, needed some assistance in reconnecting with that treatment once he was outside as well. One of the big factors, I guess, risk factors that we saw for Max was that he did have a history of non-fatal overdose. So that was a really big flag for us as counsellors, what we would talk about first with Max. Max also spoke about feeling anxiety on those first few days of release, and that transition is a really big thing for people. So that was really important for us to talk about those symptoms and feelings at that time. And he had previously reported childhood trauma and had been prescribed Valium before. For Max, RHODES was his first ever support, I guess, treatment. So he'd never been connected with an alcohol and drug service before. So that was a really big step and really positive for him. In terms of protective factors for Max, he did have a child and he had one really supportive family member. So that was really positive for us. And they were a great sense of purpose in his journey and his recovery as well. So through RHODES, we recommended that once completing the 4 sessions that he connect with ongoing face-to-face treatment, so to support him with that continued abstinence, but as well as support him with emotional regulation strategies going into the future to help him in that space. I was lucky enough to complete a 1-month follow-up with Max, and Max reported that he'd started to work. He reported that he'd still continued his abstinence from substances. He was spending a lot more time with his child and with his family member, and so had a kind of increase in confidence because of those things and feeling support. And I guess it's just a really nice example of having that support at that time and what opportunities it can open for people. So moving on to the exciting parts to talk about all the evaluation. So for RHODES, we evaluated midway through the project and also at the end. So we looked at quantitative data that our counsellors collected with clients. We looked at completing 1-month follow-ups to check in to see how clients were travelling after that time, but also to receive some of their ideas for recommendations or areas of improvement as well. We completed 2 focus groups, one at Brisbane North Community Corrections and one at Caboolture Community Corrections, again, to really get that client-based experience because it's a program for them. So we want to tailor it best to what they are needing. We also conducted referral agency surveys and ADIS counsellor surveys as well at the midway point and the end as well. So some of the findings that we found for RHODES, we ended up completing 190 sessions across the 7-month trial. I guess within the early stages of development, it was hypothesized we'd have a higher number, but we had, I guess, a lot of barriers, one of them mainly being COVID. But of the 100 referrals we received, we had a 69% engagement, which is really positive because, as we know, within AOD, it's around that 50%. So that was really positive, especially with the client population we were working with. Another positive point was that the majority of clients did complete all 4 sessions. So the next kind of most common was around 2 sessions. Some clients reported wanting to take part in 2 sessions, as the first was a way for them to engage in treatment, connect with a referral, and the second was a way to check in and see how they were travelling, and also for us to assess how they've been in those first few weeks as well. But again, a significant contributing factor to clients not completing sessions was also clients who may have returned to custody in that time as well, and therefore, unable to continue sessions. So in terms of average call time was around 36 minutes. Usually session 1 was our longest session, which makes a lot of sense because we're building relationships and we're understanding the client. Our shortest sessions were generally session 4. Counsellors often reported that they found that time was adequate to complete what they were requiring to complete, but also a big factor as well was clients felt comfortable and not overwhelmed with quite lengthy sessions. We always allowed for 1-hour sessions with clients, so sometimes we did go over that time, but that might have been if there was a crisis presentation or additional support was required. In terms of connecting with people following release, it was on average around 3 days, so a little bit 1 day out of our kind of aim, but that was quite often dependent on maybe clients weren't presenting to their intake appointment to give case managers enough time to respond. Some clients wished to do their session in the 3rd or 4th day because they felt a bit more comfortable at that time. And also, I guess, telephone barriers as well was a big part of actually connecting with clients, which leads to engagement. So like I said, the most significant factor was clients being lost to follow-up or uncontactable. So that accounted for about 52% of those clients. Around 32% declined taking part in the program once they found out it wasn't, a mandated thing, or they felt that their substance use wasn't a concern at that time. However, we did find as the program progressed, we did have less people decline. And we think that is partly due to, I guess, across the services, people becoming more familiar with what RHODES was, but also, I guess, enhancement in how our counsellors engaged clients as well and felt more comfortable with delivering the program. Around 13% of clients were still in custody when they were referred and weren't released in time to take part. And we only had a really small amount of clients not meet the criteria just because they fell outside of that time frame. But it really does go to show that the case managers were really accurately treatment matching because we didn't have any I guess, inappropriate referrals at all during that 7 months time. So in terms of our most utilised referrals was definitely the opioid treatment program, followed by face-to-face counselling. In terms of indirect referrals or information, it was really common for the ADIS contact number to, of course, be offered as support in between sessions. The next was connecting with the GP, whether that was for mental health concerns or whether that was for bloodborne virus treatment. Next, of course, accessing naloxone and where people are able to find that. Connecting people with support groups like NA and AA, as well as providing general information. Quite often counsellors reported that was around housing, homelessness and family and relationship supports as well, so we could offer contact numbers because that's not part of our specialised service. So some of the demographics, we did find that 90% of clients were male, with 10% females. Around our median age was 29 years old. So highest was people falling within 25 to 34 years old. In terms of cultural background and nationality, we had no clients report as culturally linguistic and diverse in background, and we didn't have any clients report that they were from Australian South Sea origin. However, as Heidi said before, we did have a high number of clients, around 22% report that they were from Aboriginal or Torres Strait Islander origin, which again speaks to the point of overrepresentation in custodial settings. Based on the information gathered, 100% identified English as their first language, although with ADIS we always have access to telephone translators as well, so that's always that option. However, we do advise with a multi-session I guess program that they do seek that face-to-face because we don't have those visual prompts that you have. And the data gathered displayed that 95% of participants identified as Australia as their country of birth. So in terms of substance use, while the research shows a high level of overdose in recently released people mainly is due to opioid overdose, the primary drug of concern identified by RHODES participants was clearly methamphetamine, with 63% reporting this, followed by buprenorphine, alcohol, cannabis, and then heroin. Commonly, clients would report that methamphetamine use would occur prior to incarceration. Then whilst clients were incarcerated, they'd switch to use Suboxone, or, well, it was called Subby, or it was also called a day off that we learnt as well. In terms of the method of use, it was found that 67% reported intravenous drug use as a current or historical method, and then around 33% reported to smoke or swallow in terms of use. And of course, these findings do align with current research and suggest that intravenous drug use does increase people's chances of overdose as well. As Heidi said, we use the assist to measure substance use within this program. And we found that 40 clients completed this because we chose to put the screening tool in session 2. It was found that the most frequently reported substance was tobacco, with 90% of clients using that. And then, of course, that was followed by methamphetamine, alcohol, cannabis, and then opioids. On smaller levels, we did find people reporting cocaine, sedatives, hallucinogens, inhalants, and GHB as well. But of course, we found that measuring, I guess, risk factors, amphetamine type substances, as well as opioids, were always the most highly reported. So in terms of, I guess, this client population, it was imperative to consider how the program may impact or influence recidivism and mental health. Based on the literature, it is understood that commonly people released from incarceration may be more likely to return to custody within those early months of release. Self-report data from clients displays that this was a common occurrence for RHODES clients. And we will be looking into further kind of research into the future around the RHODES program and how it does impact recidivism. Several clients would complete 1 or 2 sessions of the program, however, would be uncontactable due to returning to custody, or counsellors would actually contact clients on their way to having to return to custody, unfortunately, so they were unable to engage. In terms of mental health concerns, some clients reported a current or previous diagnosis of mental health. And in addition to clients reporting possible symptoms of mental health, however, had not been engaged with mental health services before, so that was a big deal for them. Furthermore, it was identified that a high proportion of clients that were released from custody were incarcerated due to domestic violence and family violence or violent offences. So as a result, we included emotional regulation strategies within the RHODES program, just to briefly touch on and identify emotions and how to manage that for that particular population. Lastly, for me, we will talk a little bit about the specific intervention. So what counsellors found that they most utilised with clients. So probably unsurprisingly, the normalising that transition into the community was always our most utilised strategy, followed by harm reduction. The stage of change and treatment matching to that, high-risk environments, goal setting and creating routine were within the top 5 most employed strategies, which really paints a picture of what people are requiring at that time. Coming from a very structured environment out into the community is very overwhelming. Additionally, interventions that were not included, however, frequently used for the RHODES program was, of course, relapse prevention, craving management and stress management. And quite commonly, counsellors would report clients speaking about relationship concerns upon release, family support, and also grief around not seeing their children whilst they were incarcerated, and then maybe not being able to see them when they had come out as well. So it was a lot of conversations around grief and loss, which is not always, I guess, in scope of an alcohol and drug service, but we'd like to meet our clients where they're at that particular time. And I'll pass you on to Heidi to talk about challenges and barriers.
Thanks, Michaela. So of course, like most projects, we did have some challenges during that trial period. And of course, unsurprisingly, COVID-19 pandemic was a big challenge for us. It impacted our ability to be able to recruit a counsellor to support the project for a period of time. The number of referrals we received from Queensland Corrections was impacted due to changes to processes and releases, as well as the overall project budget was adjusted. The first session time frame was a challenging deliverable, as Michaela's talked about and I spoke about, clients not having access to a phone, not being able to report to community corrections within that time period, or not answering their phone because we ring from a private phone number. and clients may have requested to have their first session at another time due to just having so many commitments at that time when they're being released from a custodial setting. Contacting clients was difficult at times. Some clients gave contact numbers of family members or friends instead because they didn't have phones, and some clients returned to custody. Obviously, finalising the information sharing deed, that was an important step for the RHODES project due to sharing information between services. So the delay meant that we were unable to provide statements of attendance until after the 3rd month of the trial beginning. So that impacted on the number of referrals that we received. However, we tried to mitigate that by providing a statement of attendance directly to clients to be able to share with their caseworker. At that time, we also had the introduction of Stigma. So the Alcohol Drug Services implemented a new database to be in line with the mental health services. So that meant a lot of processes had to be changed midway, sort of partway into the trial, and staff had to learn new processes and procedures. Also having to sort of implement using the assist with the intervention. Accessing naloxone. Naloxone is a drug that can temporarily reverse opioid overdose by injecting intramuscularly or delivering it by an intranasal spray. A large majority of RHODES clients reported a history of opioid use or buprenorphine use whilst incarcerated. So if clients had used opioids, it was pretty important for ADIS counsellors to try and facilitate some naloxone for them. So we know many clients will kind of return to previous patterns of use. So within the Metro North region, there is not a huge amount of locations that can offer naloxone at no cost. And whilst clients can access it from pharmacies and GPs, there was some, concern that they may experience stigma if they were to go to those places to obtain the naloxone, and geographically, the locations where they could obtain it for free was not accessible to everybody. Connecting with ongoing treatment, obviously, we know there's barriers, we know there's wait lists. So even though RHODES client referrals were priorities, there was still a wait list, and due to time in between referral and engaging in service, a lot of clients lost motivation and didn't engage or experienced a lapse or return to custody before their appointments when they were provided step-up care. Look, I mean, Michaela talked about, we had a lot of evaluation processes, but even before we started looking at evaluation from early on in the project, we started receiving feedback directly from clients, unsolicited feedback from clients and from services, from corrections and other alcohol and drug services, saying that clients were having a really great experience of being engaged with the RHODES program. So, this is some of the feedback before we even started doing any evaluation, which I think just kind of speaks to, how engaging the ADIS counsellors were with clients when they were talking to them. I'll just read out one of them. Client never believed in psychologists or counsellors until he participated in the RHODES program. He stated it had been a great experience so far, and he's learnt a lot more strategies to help his substance use over the last 3 sessions, more than he ever has. So there was some consistent findings as a result of the evaluation. All clients that were involved in feedback reported they found the program to be helpful and it was relevant to their current situation. They found it non-invasive, it made complying with conditions of release easy, it helped maintain their motivation, and it was stress-free due to sessions being over the phone. Recommendations included offering additional sessions if needed and some kind of transitional care by being told about the program prior to release. Clients were reporting an experience that was non-judgmental and identified the theme of being treated as a human. Referring agencies reported they were noticing changes in people that they were supporting, with benefits of the program being that there was no wait list, and it was non-judgmental. Around about 78% reported that it was better than other treatment services available, and with others reporting it was equivalent to other treatments. Recommendations again included offering the option of ongoing sessions and inclusion of transitional care or education about RHODES for people whilst they were in custody. Counsellors reported that RHODES assisted their clients with increasing safety, motivation and willingness to seek support. They were seeing longer periods of abstinence and had increased awareness around their substance use and triggers. Counsellors had recommendations about including more emotional regulation in the program, also the opportunity to include more sessions and some potential ability to reduce administrative tasks. Counsellors also reported a common theme of being told they were being treated as a human. Some of the learnings that arose from the program trial, there was some common myths that I'll just kind of touch on. One of them was surprising to me, that hepatitis C treatment is painful. As a result of the program, counsellors would discuss bloodborne viruses and encourage clients to seek medical advice to continue treatment or access treatment. And many clients had reported they'd been told by other people in custody that the treatment was painful, and that's why they chose not to take part. So counsellors were able to dispel these concerns and directly try and get the clients to engage with the Hepatitis Queensland service to get more accurate information. Another one was that the opiate treatment program is available for methamphetamine dependence. It wasn't common for clients to be unaware that this treatment program was only for opioid concerns. So it became common practice for counsellors to talk to clients about this topic. There's no such thing as methamphetamine overdose. Several RHODES clients reported being unaware of the risks of overdose when using methamphetamine. Many clients were aware of opioid overdose and the signs and symptoms as they'd either experienced it themselves or they had had a friend pass away from accidental overdose. Whilst, they were aware of the opioid overdose symptoms, they were unaware of symptoms of overdose from other substances. So within the RHODES resources and during RHODES sessions, it was a good opportunity to employ psychoeducation to support the client's safety and increase their awareness. An interesting finding, Michaela's already spoken about it, the availability of buprenorphine in correctional centres. It seems to be the substance that people use if they are using when they're in a custodial setting. So whilst, people may not primarily be opioid users, they would use buprenorphine when in custody. Another really interesting finding and a feel-good thing, which corrections may be interested in. Clients were reporting that they had informed their case managers how they were progressing with RHODES, and they felt comfortable talking about whether they'd had a lapse. Clients reported they felt they could be open and they would be supported and not reprimanded for their honesty. I guess working in the alcohol and drug space, that's not something you used to hear from clients, but we can only sort of theorise that the change was in relation to not immediately being breached due to a positive drug screen. And this is enabling them to have a better relationship with corrections. So stigma. I think it's important before we wrap up to specifically speak about stigma. Within the alcohol and drug sector, unfortunately, it is common for clients to report experiencing stigma. For RHODES clients, many experience stigma not only for their substance use, but also for their previous criminal convictions as well. So it was observed that many clients were experiencing self-stigma in which they would agree with stereotypes or internalised public stigma. And many clients reported feeling unable to leave their home, or when they were in the community, that people would be able to know just by looking at them that they'd been incarcerated. This impacted their ability to reach out for help, engage in community groups, seek employment, as well as feel worthy to access treatment. Regrettably, several RHODES clients also reported feeling stigmatised or judged when accessing alcohol and drug services, which was observed by ADIS counsellors directly. Clients stated they felt interrogated when they took part in intake appointments and felt as though their intentions to access treatment were being judged. ADIS counsellors reported being asked to verify what clients had reported in their intake sessions, and quite often counsellors felt they had to advocate for these clients in contrast to usual ADIS referrals. In addition, internally, it's been seen that language and terminology was used when discussing RHODES client, which was observed to be quite stigmatising. I mean, we see the concerns of RHODES clients as a health issue, and continuing stigma is only delaying or stopping these clients from connecting with treatment. A person with lived experience that provided feedback during the development phase of the RHODES program stated to us, "I try not to define myself on that I went to prison, because I know that I am more than that time." The recommendations coming out of the program trial, obviously, the recommendation would be that the RHODES program continue and expand statewide in the future. The RHODES program has proven to be a cost-effective and viable solution for the gap in support. For the program to continue, however, and expand, additional funding would be required in the form of more counsellor positions, database updates, as well as a project officer role to expand the service delivery statewide. And that's not something that's available to us at this time. The recommendation to develop a booking system would reduce administrative time and enable us to provide statement of attendance to corrections, in a timely manner. Offering additional sessions was a common theme among everybody. So the opportunity to offer additional sessions where required, or if we're linking people into step-up care sessions between until their appointment, their face-to-face appointment. Anyone who's worked in this space knows there is a lot of recommendations to providing naloxone, to providing the actual medication on release from custodial settings, and we support that recommendation. We believe that anyone who has current or historical opioid use concerns be offered this life-saving medication. Promotion of the RHODES program within correctional centres, if it were a program that was continued to be offered, to introduce the idea of that early while people are in custody. And of course, around stigma, it's recommended that additional training or addressing stigma across services about working with clients from this population group, so to increase awareness of stigmatising language. So just to finish up with, we have a lovely quote there from a person who participated in the RHODES program. RHODES is like someone holding your hand through the first few weeks of release, which I thought was a really nice thing to say. And at this point, I really wanted to say the RHODES program wouldn't have been successful without all the people supporting it. Obviously, we consulted with a lot of different people, our partner organisation, Brisbane North Community Corrections, the ADIS counsellors, specifically Ashini for being the main RHODES counsellor and providing a lot of those sessions. Staff involved in the consultation of the program, in particular our medical director, Dr. Jeremy Haler. And of course, Seed and Link funding. Without the funding, we wouldn't have had the opportunity to trial the project. So I know I've gone on and on, but questions?
Not at all. I'm wondering if we might want to invite Michaela back up so that we can, put it to you in terms of how you want to respond. But thank you first. We've had some wonderful and lovely comments come through already. So thank you for those out there who've done that. And we've had quite a few questions come along. And I gather we have a large interstate audience because we've had a few comments from New South Wales and Victoria as well, which we'll try and address as many as those. But firstly, I just want to say thank you for some of the focus that you and the themes that you expressed in that very important focus on treating this cohort as human beings. I like the fact, I also support you very much in that idea. This is not treatment resistance. This is being in two minds about things, being uncertain, unsure is is completely normal for all of us in life when we're negotiating major changes or major transitions. So thank you for bringing that to our attention again. So a couple of questions. I'll probably not necessarily do them in order, but just a few shout outs initially. I know you mentioned that Metro North, obtaining an naloxone is difficult. Probably in Metro North, we have more options than anyone.
Well, no,
which,
not specifically.
No, I know. We had someone who came in from Quinn
Yes.
who provide that for free for people.
Yes,
and if
they
anyone
would.
who's
They
wanting
do.
to, and I know that's local to our area, but it's a good opportunity to put as much word about these life-saving options out there. So that's Quinn, QUIHN.org for anybody who wants to kind of find out a little bit more about what they're doing in that space. Some other questions. So from your research and from your sort of development, are you aware of any of the other ADIS services who are providing a similar type option? Because we had questions from New South Wales about that. Victoria, I think, would love to be, or someone in Victoria would like to be seeing this happening.
Unfortunately, no. We have spoken to the other ADIS services. They are aware of the trial of the project here. They find it quite interesting.
Yeah. Sorry, I'm standing in front of the camera. Sorry, I thought the camera was there. Don't worry about me.
Yeah, so we have spoken to some of the other ADIS services. It is not something that's being offered there. It is trialled here, and I guess we wanted to see the outcomes, and we hoped that, you know, due to the success of the trial, it is something that other services would consider looking at.
Yeah, definitely. Just on that, with the plans for continuation.
We're working on it. At this point, you know, there's no clear funding avenue. But it is something we will continue to work on. And I think it is definitely a priority area for the alcohol drug services generally. It is for us at ADIS. It's definitely for Michaela and I. And I think it is for corrections as well. We get questions all the time about, why aren't you offering this here in Metro South or here or here? Yeah.
And I think that might answer a question from somebody from Toowoomba who was wondering about whether they could refer people. At the moment, it is Metro North because of the funding and the trial nature.
It's ceased.
Yeah, exactly. I love the way we pilot things that are common sense. But anyway, we'll see how we go. I might just, I have other questions that have come in online, but we also have a wonderful audience in the room. So I might just open up for anyone from the room that may want to express a question. That's okay. You can think on that. I'll come back to you in case anything pops up. I think we're still going okay for a little bit of time, but if anyone needs to leave, but if you guys are happy to stay around for a few more questions. Again, I think some of these might be able to be fairly simply answered. So clients needing OTP, can they get access through this program? I know released prisoners have a priority anyway in Queensland for the opiate treatment program. Do you find that that's a kind of, you spoke about step up and linkage and referral, is that something that also you have connections for?
Yeah, so the direct referral that I spoke about at the beginning, we have a lot of direct referral pathways into treatment, particularly in the Greater Brisbane area, and that allowed us to streamline treatment for those clients requiring opiate treatment therapy. Yeah.
Definitely doing some of that intake work up front. Terrific. There was also an endorsement of the issue around the non-medical use of buprenorphine or subby in correctional centres, and that came from New South Wales. So certainly not just a Queensland thing. Don't know the answer to that one, but just an endorsement around the fact that that is something that's occurring, I guess, nationwide and in many jurisdictions. I know you mentioned, I think it was around 36 minutes you said was the average, but there was a question around how long each session was planned for.
So we always provide clients with that hour session. And so then, as we said, it always client focused on how much time they felt was required, but we always allow within our structured interventions in ADIS the hour mark.
Sure, absolutely. And I think we have to readjust our ideas of this kind of like what is a counselling session, that it is the standard hour. It's about what's effective and what people are able to engage for, and I think that's brilliant. A question, and you may or may not have looked at this, but there was a question around how this particular program might have considered where it supplements or where it is different from the programs that are currently run by correctional kind of type agencies, there was a comment around that they've not been particularly successful, or the ones that also look at addressing recidivism. Were there opportunities that you saw, or was there any planning around how they might supplement each other or be different from?
We worked pretty closely with some of the prison re-entry services. None of them are alcohol and drug specific, and they don't usually provide alcohol and drug intervention themselves, though some of them will go into custodial settings and provide groups. So they will do a group sort of education around alcohol and drug, which I think is very different from a one-on-one session, even though it's over the phone, which is specifically tailored to what's going on for the client.
Yeah, definitely. And I think you've already spoke about the fact that probably a lot of the gold where you've had the success is that ability to engage people, to be able to have them experience being treated like a human being, and all of those types of things, and the which is your groundwork for building anything else on. Can people be referred to this program while they're waiting for support that might take, as you mentioned, the services all being at capacity and not enough sort of services to meet demand? Can they be referred to this from outside of Metro North while waiting for that support to kick in?
At this point, RHODES is not available.
I can understand why you have to put limitations on things, because absolutely, we'd like these things to do all things.
But keep in touch, and hopefully at some point it will be.
There's a lot of questions here from outside of I think this area around, and I'm assuming and guessing that any longitudinal is looking at that kind of wider application. But these things are hard to get up to scale in the way that they need to be. Just some, can anyone refer, if consent is given, is it all client contact conversations, or can anyone refer who isn't the client, subject to them having consent? I mean, that's always a bit tricky in the sense of what people interpret consent as.
Yes, but, I guess so. Part of our information sharing agreement, our deed that we developed with corrections, was that we require that clients sign all the verbal consent to be provided before they engage. So that was a big part, and it's a client-directed program, so it's most important to come from them, that it's their decision to take part. But there is all those legal requirements around providing that consent as well.
And that avenue was chosen because we knew that clients were required to, within a timely period, access, community corrections. So it seemed the best opportunity as a referral pathway, as also re-entry services, because not everybody has reporting obligations once being released from custody. So,
yeah, definitely. And in terms of the follow-up, is there any plan for that to extend beyond the 1 month, given that we know that the sort of the longitudinal and to stage do repeat administrations of the assist to see where those substance involvement scores fall? And that sort of thing?
I think the only factor was our year period of the project. Of, I guess we had that 7 month was pretty strict, but ideally we would love to do a 1 month and then a 6 month and have that longitudinal view of how clients are travelling as well.
Sure.
For sure.
And some of our attendees out there today very, very nicely have a much bigger view of the issues that are impacting on people who are exiting and being released from custodial environments, in terms of it's not AOD only. So they've spoken here about those, do you find that you have built, and it's not all, I guess it's also not always on a small service response that's piloting, but the needs of life are so much bigger than just addressing the alcohol and drug issue in terms of all the social determinants and the other things. So there was questions here about, do you help with employment? Do you help with all those other sorts of things that are going to help give people good lives outside of prison, which is often, and the connections and things? Do you find that that's happened just organically? or it's not all on.
Yeah.
I know there should be other agencies involved doing these things as well.
I think that was our big part of the RHODES project, was maintaining scope, because we see as counsellors, just because we work for an alcohol and drug specialised service doesn't mean we don't see people in a holistic manner, and know that all of these external factors, such as if they don't have housing, if they don't have financial support, if those things aren't in place, how can we then look at substance use when those basic needs aren't being met? So that was a really big factor in acknowledging that, but I guess what we can do within our space, but then it lends itself to...
But the conversation was had around well-being generally, and looking at the other things going on in a person's life. But a lot of those concerns, if they were ongoing, would be referred to re-entry services and other services that are more specialised in that area.
Absolutely. Yeah, I can understand that. So I believe we are getting close to time. So I do apologise in advance again if we don't get through everything that people have put in the chat, or particularly it's come in just in the last few moments. But I'll just come back to the room now in case anything has permeated to the top front of people's mind. We do have a lovely audience here today. We're very kind of
probably used to us talking a lot about it already, so they know all the answers.
Some of your colleagues, exactly. No, that's terrific. I believe we have a few moments longer. Niall, let me know the time. 11:06. Oh, I can probably look at the clock. If anyone needs to go, we have gone over time, but if you're happy to hang forward just a few more. The 24 to 48 hour release period. And I guess this is probably a question from myself, having worked alongside supporting people released from custody for many, many years. Often that's a period of, I know there's lots of reporting going on to the correctional side of the equation, but it's also a period where people maybe are feeling quite committed to their sense of being what they're going to do, and not necessarily some of the aspirational versus the realistic, I guess, in terms of maybe around skills and coping and the barriers that they're going to face and experiences. Was there any thought of kind of expanding that out, given that in that period it may not be that I think I've got any issues, or I'm not?
We weren't completely inflexible, but the aim of the project is to provide early intervention and release. So if the person is willing to wait some time, they could engage in some of the face-to-face services.
Absolutely. And I see where this is being one of the big drivers from this, in terms of just that vulnerability and risk for people. So that's brilliant. And it sounds like, from the feedback that you received and particularly the qualitative feedback, that you were able to build confidence and trust, which is often difficult. And I know you spoke a few times about information sharing deeds and sharing attendance. Was that all that you had to share, given that that's often what's required because of the concerns and the fears around the punitive responses?
Yes, so part of our, information that we shared back was the dates of when people attended. So that would list, it could list 4 dates, it could list 1 date, and it would be dependent on if the client had actually engaged. So if they didn't engage, no statement of attendance would be sent. Obviously.
The only other supporting information that was provided other than that was were they referred into a specialist alcohol and drug service, though we wouldn't be specific about what that was. We know that actually supported clients with meeting the requirements for correction, so it was actually a benefit to them. A lot of them wanted that to happen.
Happy to have it sent.
No, that's brilliant. Again, it just allows you to work within that health space and not feel like you're being an agent for other agencies, because this group is entitled to receive a health response to these issues. That's completely important. Look, that's probably, I'm just going through the quick list here, so I'll just Niall, is there anything important you think that's come through in the last few moments? We'll try. I don't think we'll get through all of these. Thank you for everyone for being engaged today. So we've spoken about the funding. The trial is for the year. Okay. Sorry, I might try and... Who approached the prisoners? Obviously, we're talking about in custody here, and obtained consent, or who approached the individuals and obtained consent for the RHODES program while they were in custody? Is it the correctional staff or the AOD clinicians or nurses?
So generally referrals were received from community corrections, so they'd actually already been released. However, we did at one point evolve that, and re-entry services started referring in. So some re-entry services have transitional care, so they go into the custodial setting. So at that point, clients were saying, I want support, and they were referring them in, but we weren't quite sure when they were coming out, and it didn't work very well.